Cairns and looked at some of the quotes that he delivered during the course of his brilliant and decorated career, I identified with the need of really merging a clinical neurological career with one where you could be involved in the latest and cutting edge of science. After my neurology training, which I did in the United States at the Mayo Clinic, I was very fortunate to return to Oxford as a clinician scientist, where little did I know I was in one of the Nuffield departments that really was something that was inspired by Lord Nuffield, who was critical in really defining Hugh Cairns' career as being appointed the first Nuffield Professor of Surgery at the University of Oxford. And returning to Oxford, I really got to experience a marvelous and decorated experience of young and bright scientists interacting with the wise and colorful who were shedding their wisdom, trying to be the absolutely most outstanding mentors to advance science for the translational benefit of patient care. And with that, I have been able to devise my own research group at the Department of Clinical Neurosciences at the University of Oxford. You can see here in this slide, I now lead the Neurodegeneration and Inflammation Research Group, where we engage in looking at the cutting edge of neuropathology by trying to integrate it through analyses by looking at genes and how they influence pathology, looking at how genes are expressed and what proteins are expressed and how that links to pathology, looking at what the MRI scan shows that we see during life and how that actually translates into pathology we see under the microscope. But relevant to today and the talk that will follow about Sir Hugh Cairns, I have also developed a passion through the guidance of my mentor to look at diseases of the central nervous system in a novel way. I have primarily had an opportunity to look at inflammation and demyelination in multiple sclerosis, but that disease also has an important component of degeneration, and that really has broadened my research focus to look at diseases where inflammation and degeneration are important factors that may align. And with that, I've launched into a career looking at comparative neuropathology, comparing one disease to another. Now, while my focus remains multiple sclerosis, I'm also now passionate for looking at how degenerative diseases, for example, like Alzheimer's disease, may have inflammation associated with them, but also other diseases where we see both elements of inflammation and neurodegeneration that may be relevant and studied in different ways to provide insight into diseases like MS and, for example, Alzheimer's disease. And one such example is looking at traumatic brain injury. And this was a huge passion for Hugh Cairns in his career. As a neurosurgeon, he often cared for the sickest of patients during World War II, and in fact led a campaign here at Oxford to establish a military hospital for head injuries during the war. And he had the opportunity to care for and study the outcomes of patients who had significant traumatic brain injuries, some of which were due to blunt trauma, others due to gunshot wounds that penetrated the brain and left patients with significant disability. Now, we have been very fortunate to have a cohort of the brains of people who initially were under the care of Hugh Cairns in the 1940s during the war, when they sustained penetrating gunshot wounds, but then survived many decades. One patient dying most recently in 2012, where they donated their brain for research. And so really my career in trying to build a comparative neuropathological laboratory comparing inflammation and neurodegeneration from various diseases is now really being aligned at looking at these very different processes and how they may be linked in a cohort that dates back to Hugh Cairns. I've got a picture here of the military hospital, where the location of the military hospital for head injuries was, and that was at St. Hugh's College, where I am currently a fellow. And if you see here, I've superimposed a view from the 1940s during World War II of Hugh Cairns along with the rest of his surgical team, where he played a critical role in caring for these patients, but also trying to understand better how to improve longer-term outcomes. Now, one of his patients was a 20-year-old man who, during the war, sustained a gunshot wound that penetrated his brain. And he was cared for out in the field, where one of the mobile neurosurgical units that Sir Hugh Cairns conceived helped him in the battlefield, where he had immediate brain surgery, early penicillin antibiotic therapy so that he could have less risk of infection, followed by evacuation by air to come back to this very hospital at St. Hugh's College, the military head hospital. There he was cared for by Sir Hugh Cairns along with his very decorated team, where the patient, after several months, was able to have a reasonable recovery, and in fact, 6 months after injury, ended up going back to work in an automotive factory. The patient amazingly survived many decades, in fact 68 years from the time of the gunshot wound. And during that time, we had a very important, influential neuropsychologist, Dr. Frida Newcomb, who followed, along with neurology and neurosurgery, the detailed progress of these patients over the many decades. But what's remarkable is that 20 of such patients not only participated in this very long-term follow-up in terms of their neurological disease, in terms of the problems they faced after gunshot wound injuries from the war, they also donated their brains for research, and this is the cohort about which I've recently spoke. Now, I'm going to show a picture of the latest donation of the brains from World War II. So if you're sensitive to images of post-mortem material, I advise that you now turn your head away from the screen. So this patient at the age of 20 died 68 years later without dementia, and had, here you can see, a penetrating wound that was located in the left side of the brain. Now this is the left side, and this is the right side of the brain. This is the front, and this is the back. This led the patient to have paralysis on the opposite side of the body, along with difficulties with being able to feel anything. Now, during the exploration in the surgical notes that were there, one could not find the bullet. They removed as much debris as possible, but they thought that perhaps it had somehow fallen away, or if it was deposited, it would be too risky to remove. So we subsequently had this brain and thought, well, we'd like to actually image the brain to have a better understanding as to where that gun track wound lie. And so we have here a 3D view of a CT brain scan where we can see in very nice detail the different component parts of the brain and the area of bullet entry. But interestingly, when we looked closely at this brain in the CT scanner, we saw that there was a metallic object located on the opposite side of where the bullet entered. And in fact, on closer view, we determined that this was actually the bullet that entered the patient's brain 68 years prior. So this brought us back to the neuropathology laboratory, where we took a scalpel out and dissected the area that showed the metallic foreign body in the brain in the neuropathology laboratory. And what we found was astounding. We saw the actual bullet that had entered the brain from the Nazi Germans. And so from there, we subsequently had the opportunity, with the metal removed, to get very delicate and intricate views of the brain by getting an MRI scan post-mortem. And we were astonished. As you can see here, this is the left side of the brain, this is the right side of the brain. The patient, at the age of 20, sustained the gunshot wound wherein the bullet entered the left brain and actually traversed across the entire brain substance and lay on the bottom part of the right side of the brain for almost 70 years. The patient had a remarkable recovery and in fact only had some mild sensory deficits on the right side of his body. He had no signs of dementia and actually led a very fulfilling life, having employment up until later age. And so it was a really remarkable story about someone who was cared for by by Hugh Cairns. And it was really my first introduction to looking at the powerful impact he had, not only for the care of patients neurosurgically, but also learning about all of his major accomplishments in the neurosurgical realm that I'll talk about in a minute. But we're now faced with a cohort of 20 people who have sustained gunshot wounds and who now have survived decades, after which they donated their brains for us for research. And we have a unique and internationally exceptional opportunity to look at the influence of traumatic brain injury on things like inflammation, on things like neurodegeneration. We know that traumatic brain injury can lead to an increased risk of dementia. And so that's one thing that we're going to be looking at is what are the changes in these brains that have stemmed from the gunshot wounds? Are there changes related to Alzheimer's like pathology that we can see? And whether or not the impact of the gunshot wound leads to changes in the inflammation and the neurodegeneration like we see with nerve cell loss that somehow can give us clues as to why the disease happens. But if you look here closely, we can see that the brain and the tract of the bullet has a clear line of disruption. So the bottom part of this brain is clearly not going to be connected with an area above it. Well, how can we take advantage of these gunshot wounds that come in all different trajectories to understand better Alzheimer's disease? Well, Alzheimer's disease is a very complex neurodegenerative disease. The most common risk factor is advanced age. And we know that when we look under the microscope, there are certain changes that one sees in the brain that are very characteristic and also correlate with the extent to which someone has memory troubles. So for example, in these sections of the brain, you can see how in brown there is a demarcation of some features of Alzheimer's pathology. This is called hyperphosphorylated tau, which is a pathology that affects the nerve cells. Now, as one ages, you can get the accumulation of this hyperphosphorylated tau in these structures in the midline of the brain called the entorhinal cortex or the hippocampus. And about 70 to 80% of people over the age of 80 will have these changes, but not necessarily be cognitively affected. However, as people start having forgetfulness that goes beyond that which happens with normal aging, those people who have subjective memory complaints, as can be seen here with, for example, mild cognitive impairment, where they not only have the characteristic changes in the middle part of the brain, but they start spreading outwards. And then from the subjective complaints of memory loss to frank dementia, where people have difficulties remembering people, remembering the names of items, being able to remember words, being able to actually function appropriately in their daily lives and becoming dependent. As the severity of their dementia increases, we can look up here and see that, in fact, the spread of this tau becomes rather generous and goes to multiple areas that are rather distant in the brain in a very stereotypic fashion. So given this, is there a way where we can go back and look at our gunshot wounds in which have basically traversed different paths by which tau may spread to determine whether or not the tau that we see actually has connections from one part of the brain to the next? Because right now, that whole suggestion is predicated on animal models as well as looking at in vitro models, looking at a petri dish and looking at neurons and how tau may go from one nerve cell to the other. But now we have an opportunity to look at the human brain and to see whether or not tau, which we know starts here in the middle part of the brain, how does it actually spread from one nerve cell to another in a connected way to lead to pathology in distant areas of the brain in humans. So going back many years and to Hugh Cairns and his legacy, it's this very cohort that he had characterized, had cared for, that is now going to be absolutely critical in furthering our understanding of Alzheimer's disease today. Now, Just a word about Hugh Cairns, given that I'll be speaking in detail about his decorated career. He really was the quintessential surgeon, scientist, and educator, and very much an influential mentor. And what was remarkable in looking through the archives of all of that which he accomplished is that he had an unbounded passion for translational research, an absolute commitment to making sure that these research findings would translate into patient benefit. He was meticulous. He was painstakingly accurate as a surgeon and dedicated much attention in promoting neurosurgery. And in fact, people deem him really the first full-time neurosurgeon in the United Kingdom. And that's because of his persistence and his passion and his surgical excellence. But importantly, he improved outcomes with people by being a dedicated neurosurgeon. Back in the 1920s and 30s, neurosurgery in the brain was done by general surgeons. He was the first to do this full-time and showed significant benefit. And with that painstaking dedication, he also became much interested in trying to explore what happens to patients and follow them up in the long term. And during the war, he led an amazing campaign in trying to care for patients with head injuries at the military hospital at St. Hugh's. He was critical in mobilizing neurosurgical units that were mobile, that would go out into the battlefields and help people who are wounded out in the field and then bring them back to St. Hugh's College for further treatment. He worked very closely with colleagues in Oxford to start using penicillin for the first time and devised clinical trials of penicillin use, which reduced markedly rates of infection in the disease. And he subsequently went on to, with great detail, follow these patients and care for them right until he died in 1952. Hugh Cairns is legendary. As a surgeon, as a scientist, and as an educator, he has really made a marked influence amongst people across the planet and really sculpted neurosurgery as we know it. And I'm very proud to say that I try to emulate many parts of his career by being a clinician, as a neurologist, a scientist, and an educator. And importantly, he always encouraged a spirit of collaboration. And in some way, I've met one of his patients, several of his patients now, and will collaborate through a legacy that he's left in trying to understand better Alzheimer's disease. So we have a few questions that people are asking, and this is coming from the Facebook chat live audience. And so how much is Alzheimer's a genetic versus an environmental factor-related disease? And that's a really important question. Now, Alzheimer's disease is very complex in terms of who gets it, and we think that it's a combination of factors. Now, the things that are most important in terms of risk for Alzheimer's disease, the most important risk factor actually is increasing age. So as one ages, this is when we see the greatest risk of getting Alzheimer's related pathology and disease. But as our review of epidemiological literature has shown, there are many environmental risk factors that are very important and are really relevant because they're modifiable. For example, vascular risk factors are thought to be an important player in terms of the pathogenesis of Alzheimer's disease. For example, high blood pressure, uncontrolled hypertension, especially in middle age, is seen to be an important risk factor for the later development of Alzheimer's disease. Other things, for example, like hypercholesterolemia, so high cholesterol, or problems with glucose control, as may be seen in diabetes, that is also an important factor that may be important in terms of the later development of Alzheimer's pathology. But also inflammation. Inflammation in the brain and how it's incited, it seems to be an important factor in terms of later development. And we know that traumatic brain injury, for example, can cause inflammation in the brain that can last many decades beyond the time of injury, and these people will have increased risk of Alzheimer's-like pathology. So environmental factors are a very important contributor. There are genetic factors, and there are an increasing number of areas in the genome that are important, but overall, their contribution to risk is relatively low, and the focus really on research is trying to understand the interplay between genes and environment and how it ultimately leads to Alzheimer's risk.
Got quite a long one here. Can I read it out to you?
Sure.
It says, have you considered correlating mechanical strains and strain rates through finite elements analysis due to mechanical loading, for example, bullet penetration, to the location of the neuropathology, i.e. for motorcycle impact?
Sure. So that's a good question. So basically it's looking at the mechanical forces and translating how it may relate to the neuropathology that we see. Unfortunately, as you can imagine, the actual details of the mechanism of injury that one sees in a post-mortem cohort of brains is difficult to ascertain in terms of the actual force, the angle of entry, the actual rotational forces that may be there, whether or not there was a helmet, and if so, what type, etc. So there are so many other factors that would influence the actual pure interpretation of the mechanical elements of, for example, the gunshot wound with, for example, the pathology that we see under the microscope. So we really have to take a pragmatic approach, and the value of looking at something like a gunshot wound is that we have a very defined area of the brain that's affected, and the shear forces that one sees, for example, with blunt injury seems to be different. And so we can then look at the influence of a direct impact and a bullet trajectory on the extent of pathology on different parts of the brain. Great. So it's been a real pleasure and honor speaking to you, and I wish you all a pleasant day or evening, no matter where you are. Take care.